Hello and welcome back to Healthcare Finance. This is going to be the last video that you'll see related to the payment function of health insurance, as well as talking a little bit about total health expenditures in the United States. So the payment function. Obviously, health insurance is not just about sharing risk. It's not just about sharing the costs. It's not about any of those things exclusively. It also obviously serves the function of paying providers and healthcare organizations for the services that they provide. This happens through a wide range of different kinds of reimbursement mechanisms. And so it's important that you be familiar, particularly as a healthcare manager. You need to understand how these different kinds of reimbursements take place from health insurance companies. Now, the first one, the most straightforward one, is of course fee-for-service. What we see in fee-for-service is it's very simple. The provider then sends a request for payment to the health insurance company for a particular service that has been done, and the health insurance company pays the provider back for that service. For every individual service, it is an individual transaction, and this was kind of the old model. The fee-for-service model was the old model of health insurance reimbursement. We've seen a move away from fee-for-service models to bundled payments and capitation and others to try to reduce supplier-side induced increases in utilization by providers incentivizing the use of more healthcare services, ordering unnecessary tests, performing unnecessary procedures, etc. So what we see now is a move toward bundled payments, where for any particular condition, there is sort of a simple payment that is provided. We also see that there are various scales and methods for providing reimbursement. We've already talked some about capitation, which is about how many patients you have on your census, and then the health insurance company provides a fee. In a managed care scenario, they provide a fee to the provider for having those patients active in their census in that given month or given quarter. We also see a model of reimbursement that is cost plus reimbursement. So what we see health insurance companies doing here is looking at the actual cost of procedures and then making some additional expense to allow for providers and healthcare organizations to be able to cover their other administrative and other costs. So that's a model of reimbursement that health insurance companies have used. But what we really see now is a move in reimbursement toward prospective reimbursement on the basis of disease-related groups, or DRGs, or outpatient prospective payment systems. So DRGs are used in the hospital. OPPS is used in outpatient settings. They also can make payments based on what your actual case mix is or likely to be based on previous performance. They issue prospective payments, and then based on utilization, you either have to give money back or the health insurance company gives you money. There also are prospective payer models for home health care services as well. So what we see in value-based reimbursement, which is really the move that the reimbursement model is going toward, Medicare developed what we see as sort of value-based purchasing methods that incorporate pay for performance. So it's about the value that you're getting for what you're paying for the service, not just the volume. So the goal is to reimburse less, to pay for fewer procedures, to incentivize people to provide care more efficiently, but also to improve quality and reward good performance. So most organizations are now required to report quality data to CMS, or they will face penalties, and based on that quality performance, they are reimbursed at either a higher or lower level for that performance. So this is how we got this sort of value-based purchasing model. So it's not just about paying for every single encounter. It's not regardless of the outcome or the quality of that encounter. Now payment is being based on how good or high quality your organization is in terms of how it's functioning and how efficient was it. And that's how we got to things like bundled payments. In the hospital setting, we have DRGs, or diagnosis-related groups. So for each acute care hospital inpatient, there is a code for a particular condition. Now, these can be very specific, and depending on how complex the case is, there have been modifications made to this. But basically, the DRG is made on the principal diagnosis that the patient has. And so, statistically speaking, for every patient who comes in who requires a hip replacement, there is a set of things that have to happen, a certain amount of resources that are required in order for that person to successfully have a hip replacement. There is a predetermined fixed rate that is paid per case, and then the hospital must provide whatever the patient needs. So if there are post-operative complications, if there's post-operative infection, if there are any errors that take place, that is the responsibility of the hospital, because they have already been paid and will be paid on the basis of their diagnosis-related group. Now, adjustments can be made. The DRG payments are not exactly the same for a small rural nonprofit community hospital versus an academic teaching hospital, right? And so depending upon your geographic location, the cost of living in that location, and the cost of expenses, certain kinds of case mix adjustments are made, then your diagnosis-related group amounts will be different. There, of course, are refinements that are made to the DRGs based on patient severity. So, of course, not every patient requiring a hip replacement is the same in terms of the level of complexity of the care that they require. They may have multiple comorbidities. They may be more prone to other complications. So rather than just having a set of DRG codes just for whatever it is the primary diagnosis, there actually is a much larger set of very specific DRGs that are coded based on patient severity and other potential complications or comorbidities. These are evaluated and reweighted on an annual basis. And so this is a way, again, to account for some things that hospitals, of course, have to take into account themselves, which is the complexity of the care that the patient requires. Reimbursement is, of course, reduced for certain early discharges. So you're paid for a certain amount, but if the person is being paid for a typical 5-day hospital stay and you get them out in one, you're not going to get reimbursed the full amount on a DRG based system. Now, the outpatient prospective payment system, again, very similar. What you see is that hospital outpatient departments have a set of codes in which they are paid for, non-hospital ambulatory surgery centers, for example. There are 300 different codes or groups. There are ones for new technology. There is a bundled rate that includes things like anesthesia and certain kinds of drugs. And so for the particular procedures done in those outpatient ways, there's one set of codes, and then the physician services that are performed in an outpatient center are based on the RBRVSs. So that's where you see kind of this difference. There also is a case mix method of reimbursement, which kind of looks at the severity of conditions in the population that you treat, looking at comprehensively who has been treated in the past, and looking at the amount of utilization of resource that the patients that you typically treat in your organization are likely to need. So these are where you see resource utilization groups, or RUGs, are used to look at the per diem rate of reimbursement used. Now, this is for skilled nursing facilities and inpatient rehabilitation facilities. So this method is used for different kinds of healthcare organizations than inpatient hospitals. Some important terms about payment that you really should know. Charge. A charge is the price set by the provider. So the provider assigns a charge of $30,000 for that coronary artery bypass graft. The rate is the price set by the third-party payer. So the difference between the charge set by the provider and the rate by the third-party payer, if we have charge minus rate, that leftover amount typically will be paid by the patient, by the consumer, if they're allowed to charge that difference. Typically, that what happens in most cases is that what is charged by the provider ends up being the same as the rate or the price set by the third-party payer, and then the third-party payer simply pays that full amount. But in some sectors, that may not be true. The fee schedule is a list of charges of the individual fees for each type of service, right? So you see this fee schedule, which is the giant list of prices set by the provider or by the hospital. What you don't ever see is what the third-party payer is likely to pay until you get your explanation of benefits, which shows you after the fact the difference between what the provider charged and what the insurance company will pay. And that remainder is what we typically see as sort of patient responsibility. There'll be some leftover amount. In some cases, you'll be asked to pay that. In others, the health insurance company will simply not require you to pay that. So how are funds processed? How does this take place? Now, you're going to learn a lot more about this in the financial management course, but I want you at least to be familiar with the basic process of how this takes place. So the disbursement of funds. Claims are submitted after services are delivered. So you go to your provider, you receive care, the claim is submitted by the provider back to the health insurance company. The health insurance company has to verify that the care took place, and then they pay the claim, they pay the provider for the services provided. The third-party administrator, so self-insured employers contract the service with the provider. They process and pay the claims. They monitor utilization as a way of controlling costs. There may be fiscal intermediaries or other carriers such as Medicare or Medicaid, which gets involved in the processing of the claim to engage in oversight and the process of payment for those programs. So in terms of national health expenditures, what we see is that in 2010, the United States spent $2.6 trillion. Per capita, that came to $8,402 per person on healthcare spending. We know these numbers have increased slightly today. 17.9% of GDP is consumed by our economy. We already saw that some portion of that, a pretty significant portion of that, came just from the Medicare program. Now, the 2020 projections say that we will be spending $4.4 trillion on health insurance and health care in the United States, and that this will be 19.2% of our gross domestic product. So here's what we see. This is actually 2011 numbers, not significantly different. Total health expenditures, again, $2.7 trillion. And what we see is about a third of our healthcare expenditure is based on hospital care. Physician and other clinical services are about 20%. Prescription drugs are almost 10%. And then we have sort of these smaller amounts on nursing care, home health care, etc. So the big drivers of national health expenditures are hospital care, physician care, and prescription drugs. What we see is that there also are significant administrative costs built into other care spending. And so it's important to note that also other investments in infrastructure, capital expenses, equipment, etc., go in that 15.6%. What we also see, the nation's healthcare dollar in 2013, when we were spending $2.9 trillion a year, where it went was in large part, again, now 32% went to hospital care, still 20% went to physicians and clinics, and about 9% on prescription drugs. Here we see a more detailed breakdown of some of those other costs. So we have dental services included here at 7%. Government administration and the net cost of health insurance at 7%. Now, just by comparison, in most countries that have national health systems, their administrative costs are usually 1 to 2%. So many of those administrative costs and other expenses come from the fact that we have this mixed public and private system, and many of those administrative costs come from the private sector. We have 6% in terms of health infrastructure investment, and about 5% of nursing home facilities and other kinds of care. We see we spend a very small proportion of our national healthcare budget on governmental public health activities and others. So what we see again is that hospitals really are the driver. What you see in the textbook is that there is an ongoing shift from private spending to public spending. We're going to be spending much, much more overall in terms of financing the Medicare and the Medicaid programs and increasing those roles. But in these diagrams, much of that public spending is being spent on hospital care, physician care, and prescription drugs. The ACA is going to begin radically shifting the ratio towards public financing starting here in the next few years. And so what you see in the textbook is these costs really shifting over time. So value and affordability is really going to be the buzzword in the next 10 years in healthcare. We already see the Center for Medicare and Medicaid Services pushing organizations to be accountable for their quality, reimbursing on the basis of value. We know that 30 million people will continue to be uninsured just in the next couple of years. And so making health insurance affordable is a big issue. Getting them onto the Medicaid program is going to be a big issue. What we see is that ultimately those people who aren't insured, who still access the healthcare system, we're paying for also in our federal government budget. We're paying for those total health expenditures in terms of hospital costs and others. What we don't know and what is yet to be figured out is that a lot of the healthcare utilization costs in these projections are left out because they're unknown. It's unclear how many people will sign up for health insurance, and therefore we don't know how accurate a lot of these projections are. We also know that many of the ACA's provisions, particularly the ones that will sunset, will result in higher insurance premiums for consumers and probably will result in higher taxes in order to keep the Medicare and Medicaid programs afloat. Other big issues, these issues related to risk selection and adverse selection. We know that high-risk individuals are likely to enroll. We know that the high-risk pools are no longer required under the Affordable Care Act. So low-risk individuals need to enroll in these plans to prevent the death spiral from happening. Whether that's going to happen, we don't know. Also, employers who typically have younger workforces, think about the tech companies, the Googles of the world, companies out in Silicon Valley, they are likely to opt probably for self-insurance and to administer their own health insurance plans because these are populations that are by and large healthier, where they can engage in health promotion strategies. And so keeping those people out of the small group market in the exchanges could have a significant effect, because if the only people participating in the health insurance exchanges are not the young healthy workers, but the middle-aged and older workers who are likely to have more health problems and therefore spend more, it's going to drive those premiums up in the small group market in the exchanges. And that's another unknown. So one of the things that people ask all the time is, given that the baby boomers are going to be using the Medicare program and have the possibility of bankrupting it, given that there are all these new people that are being added to the health insurance rolls and the Medicaid program, given all this additional health expenditure that's going to happen in the total health expenditure budget, how are we possibly going to be able as a country to pay for the additional expense that the Affordable Care Act requires? And so I want you to watch a short video, again from Healthcare Triage, about how we are likely to be able to pay for Obamacare and how it's probably going to end up, if current projections hold, being budget neutral for the federal government.
Wear brown shoes after 6.
So after our first video, we got lots of comments which asked us how Obamacare could possibly be paid for. Lots of them weren't very polite about it. But because of the new YouTube Google Plus commenting system, we can't go back and answer the comments in the old video. So we thought we'd make a new one right now. Welcome to Healthcare Triage. Let's start with the fact that the cost of Obamacare and its effect on the budget change from year to year. Also, anything in the future is just a projection. It's a best guess. Also, the more years you look at, the more it's going to cost. For the purposes of this video, we're going back to the beginning. When the law was first passed, all the calculations looked at its first decade. In other words, the numbers were valid from 2010 to 2019. They were calculated by the Congressional Budget Office, or CBO, a nonpartisan organization which works for Congress. All of Congress, not one party or the other. As many of you noticed, there are a lot of goodies in Obamacare. The Medicaid expansion, for example, was projected to give free health insurance to about 16 million people. That wouldn't come cheap. In fact, the CBO projected that the Medicaid expansion would cost about $434 billion over a decade. The subsidies and the exchanges cost money too. 16 or so million people receiving subsidies would cost the federal government another $464 billion. There were also some small business tax credits in the law for the first few years. Those cost $40 billion. Add them up, and the projected 10-year cost of the ACA was $938 billion. And $938 billion is a lot of money. But that doesn't mean there wasn't a plan to pay for it. There was. We were going to get the money from Grandma, probably with some advice about not diving into the shallow end of the pool. In all seriousness, the first big source of money is Medicare. Specifically, it was in the Medicare Advantage program. You see, back in the Bush administration, a lot of people thought that private insurance companies could do a better job of providing Medicare insurance to elderly Americans than the government could. In fact, this had been an ongoing debate for a long time. President Bush signed into law a new program to have the private insurance companies give it a try. Qualifying companies could receive the same amount of money that we would spend on government Medicare. If they could provide the benefits for less money, they could keep the extra in profit. Sounds fair, right? Well, it quickly became apparent that they couldn't do it. After all, there are lots of expenses in private insurance that aren't needed for government insurance. The government doesn't have to advertise or pay executives, and the government doesn't care about profit. So the private insurance companies got the government to start paying them extra. Eventually, it was costing us 14 cents in the dollar more for Medicare Advantage than for Medicare itself. Obamacare ended that practice. Private companies could continue to provide Medicare to elderly citizens, but we went back to the original deal. They got the cost of government Medicare and not one dime more. After all, that was the original intent of President Bush's program. The savings for this change? $136 billion. Alterations were also made to the way that Medicare would update the fee-for-service payment rates for care. Fee-for-service has always been a problem because it incentivizes you to do more, even if that more is unnecessary. That's a bad model. Savings? $196 billion. Medicare also used to pay what's called a disproportionate hospital share payment to providers who take care of the uninsured. But Obamacare is going to reduce the number of uninsured. Those DSH payments are no longer needed. Savings, $22 billion. There's some changes to how Medicare reimburses home health care for $40 billion. Some changes in how they paid for seniors' drugs, which actually cost $43 billion more. A revision to the Medicare Improvement Fund for $21 billion. Some reductions in subsidies to rich people who get the Medicare prescription drug program for $11 billion. And finally, some changes were made in how Medicare programs relate to each other for a $29 billion savings. Add all that up, we saved $417 billion alone from changes to Medicare over a decade. But Grandma can't foot all the bill. Remember the individual mandate and the employer penalty? People and companies are going to pay them. That'll net the government $69 billion. There are also some new taxes and fees on health insurance companies, medical device companies, indoor tanning, and other providers. Those will bring in $107 billion. There are some cuts to Medicaid, including cuts to its disproportionate hospital share payments. Those are worth $45 billion. And taxes. A new Medicare tax of 0.9% was passed on individuals making over $200,000 and couples making more than $250,000. Regular old Medicare tax was also added to unearned income over those amounts. That'll bring in $210 billion. Starting in 2017, there's also a 40% excise tax, or the Cadillac tax, on insurance, on the amount paid above $10,200 for individual coverage and $27,500 for family. Granted, not many plans are that expensive, but even so, this will bring in $32 billion. What's left? First, some miscellaneous healthcare provisions. These included increased tax revenue from coverage provisions, $46 billion, ending the cellulosic biofuel producer credit. Is that really a thing? Oh, okay. Anyway, $24 billion. Changes in how payments to corporations are reported, $17 billion. A change to medical expense deductions, $15 billion. And some changes to health savings accounts and flex spending accounts, $19 billion. Total for these, $149 billion. Finally, there are some changes to other programs whose savings were applied to Obamacare. These included education reforms, including the student loan program and Pell Grants, community living assistance services and supports, and public health programs and community health centers. Add those up for a final $52 billion in savings. I'm still not convinced about that cellulosic biofuel thing. Are you sure it's real? Add that up together and you get $1.08 trillion in revenue and savings. In other words, that's an increase in funds available in the federal budget of more than $1 trillion to pay for Obamacare. Since it was projected to cost only $938 billion, that means that Obamacare reduces the deficit. I know, it's hard to believe, but you have to remember that the law is more than just the good stuff. It's so long and complicated because it also includes all these taxes and savings. That's how we pay for Obamacare. What's even better is that as we move forward, the taxes and savings get larger faster than the expenses, so it reduces the deficit even more in the future. You will hear people say that this isn't true. Most of them say so because they believe the government will repeal the taxes or stop the savings. Maybe. But that'll take an act of Congress. Congress isn't doing much lately. But if you don't want Obamacare to cost more, don't let them make the changes. Tell them to keep the medical device tax. Don't repeal the excise tax. Keep the tax on tanning. If we do, and we pretty much have so far, Obamacare will be paid for. But not cellulosic biofuel, evidently. Thanks, Obama.
So, this gives you a very detailed representation about how the Affordable Care Act is likely to be paid for. And so the complexity in the law was in large part due to the complexity of the sources that were necessary to find the funds to finance all of these changes that were happening in the healthcare delivery system. Ultimately, what we see is that the Affordable Care Act is going to expand coverage and reduce payments to hospitals and other providers. Ultimately, this cost shifting, not cost sharing, but cost shifting, is likely to occur on the part of insurance companies, which will also result in premium increases for both employment-based as well as exchange-based plans. So at one level, hospitals and other providers are going to be paid less by the public sector as well as by the private sector, and the employer-based and exchange-based plans are also going to have higher premiums to cover for all the fact that there is going to be much more risk in this population. There are going to be many, many more expenses. There are also going to be significant administrative costs and, of course, significant profit going to the health insurance companies. So this is what we're going to see in terms of cost shifting. What we expect to see is to continue to see premiums to increase just as they have over the past 15 to 20 years. What we see, of course, is that premium increases are growing much, much greater than the overall rate of medical inflation, and much more than workers' earnings are growing. So what we see is the continued struggle on the part of workers. Even if you have employer-based health insurance, increasingly large percentage of your annual income is going to be spent on the cost sharing to pay for these increasing premiums. What we also see here, of course, is that premiums are continuing to rise. And while these rises are capped and are regulated by the federal government, we see that these increases have continued steadily over the last 15 years and show no sign of stopping. So ultimately, what can we conclude about healthcare finance after all of this information about the private sector, the public sector, all these different programs that provide funding and resources and incentives to control spending and to control utilization? Obviously, the Affordable Care Act has changed many different aspects about healthcare finance. Increases in insurance coverage for Americans is obviously going to balloon our overall health expenditure budget. But through modifications as a result of the Affordable Care Act, one would hope that increasingly that these healthcare expenditures are going to be paying for higher quality care, more efficient care, and are going to result in less waste and less fraud because of these consumer protections that are being put in place, as well as significant cost sharing that's taking place. Finding a way to finance public expenditures in the healthcare system is definitely going to require us finding ways to rein in some of these other things. and finding other sources from within the federal government to pay for those expenses. Private health insurance increases are almost always going to be coming out of your and my pocket in the form of cost sharing, and these premium increases are almost guaranteed to continue, hopefully resulting in disincentivizing any unnecessary care and making people more aware about how healthcare is being paid for and delivered in the United States.